Good afternoon, and thank you, Dr. Praful and Dr. Shefali, for including me in this interesting instruction course. And I must say, Dr. Shefali is a very good and competent surgeon,
Prolific and
brave surgeon, and she can do everything manually. So, but I don't prefer manually, although I've learned in fellowship, but shifted totally to automated. And I think if we are charging good, so we should give the best. Okay, so no financial disclosures in any of the techniques mentioned here. So this is just an introduction slide. It's already covered, and we should be thankful to Jared Mellis for discovering this technique and teaching the whole world how to do DSAEK surgery. The technique is simple. Just mark the cornea and do the stripping. Stripping is very simple. Just avoid the central visual axis area, and first score around the marked area, and then try to take out the desmids in toto and just examine it, and job is done. So DSAEK or DSAEK, already Praful covered that this A stand for automated and DSAEK is a manual DSAEK. So this surgery has 3 steps. First is donor preparation, second is recipient preparation, and third is donor lenticular insertion. Recipient preparation is just a DM score. The scoring, donor preparation, will show it later. And the last part is donor lenticular insertion. If you have a good graft, good patient, but if you don't insert it properly, you won't get the good results. So insertion is as important as the donor as well as the recipient. So donor lenticular insertion, there are numerous techniques, more than 10, 15 techniques, devices are there in the market, and people are using them, getting good results. Although what matters is what works well in your hand. And broadly, they are categorized into 2 categories, push-in techniques and pull-through techniques. Push-in literally means pushing the graft inside the eye, and pulling literally means pulling from the opposite end of the cornea. So pull-through techniques, in pull-through techniques, the donor is docked into the main incision and pulled within the eye from the opposite small clear corner incision or scleral incision with the help of forceps or sutures or any other way. One of the most commonly performed full thickness techniques is the use of Bucin glide that I am also using currently, and the glide with the donor tissue is docked into the scleral tunnel incision or clear corner incision, and the donor lenticule is pulled into the anterior chamber by grasping the edge of the donor lenticule with the bent disposable needle or with some forceps from the opposite port. Pushing techniques, the donor is pushed in through the main incision with forceps, glides, injectors. The common instruments that are used for pushing techniques are tachofold and sheets glide, endoserters, endoinjectors. In general, these glides allow better maintenance of anterior chamber during the procedure, better unfolding and being bimanual, so it's very easy to learn and perform. So these are the common techniques that I practice: tacho, sheets glide, tan endo glide, Bucin glide, endoserter, although not much experience with the endoserter. So I started my fellowship at LVPI, and I learned sheets glide there. So sheet glide was the preferred method in 2010 at LVPI. So sheet glide is a very simple glide that we use for IOLs also. It's similar to that. You can use similar glide for the DSAEK also. Just you have to give the incision of 4.5 to 5 millimeter, place the graft and push it inside. This is the surgery that's done. Very easy, almost cheap, or almost good for SN Medical College or any other medical college where finances is the issue. This sheets glide is a very good technique for the beginners also. And studies have shown that the cell loss is around 25% with sheets glide. Although once you start doing a lot of cases, this goes down significantly. So this is a case of sheets glide. Make the corneal incision. I preferred corneal incisions in all these surgeries, and you have to inject place some viscoelastic at the end of the tunnel. This beginning of the tunnel, and this is the graft. All my cases are automated, so just you have to remove the cap, and you get a lenticule of around 80 to 100 micron. And most of the institutes are giving pre-cut donor tissues. So if you can afford, always go for pre-cut. And then with the help of Singh, just push the tissue inside. So you have seen that there is no folding of the graft. Manipulation is very minimal, just 5-7 seconds, and then simply give some saline inside so that the AC will be inflated. Don't push too much saline, otherwise graft will come out. So we have to be very gentle and careful. Take out the glide and give small air injection so that the graft don't fall on the iris. Don't inject completely, otherwise when you suture, the air will come out. so it will destabilize the graft. So put the suture, 3 sutures are good enough for these cases, and then inject air, and surgery is done. Then after LVP, I went to Narayana for another fellowship in refractive and cornea, and there I learned tackofold technique. Although tackofold technique is the primitive technique for DSAEK tissue insertion, but I have seen good results with this technique also there, in which you have to use single point fixation forceps. So you see this forceps, only at this point you are holding the graft. These points are not pressing too much, although gently, and you can fold in 50-50 or 60-40. 60-40 works well because unfolding becomes easier with this configuration. And the same technique you have to push in and then again unfold and put the air. And then I went to SNEC to Dr. George Mehta to see what he's doing. And there I saw the tan endoglide technique. Also, it's a very fancy technique, but it's costly and doesn't suit Indian economy. So although I've learned this technique, you have to place the graft here in this cartridge, put some viscoelastic here. And this is an automated system, and once it is docked, so the graft curl inside out, so you can see the double curl folding inside. And then you have to reverse the orientation and inject in the antechamber. The sad part is this is a one-time use device, so it becomes very costly. And when you inject in the antechamber, so it will automatically unfold on the stroma, and then rest of the steps are same. And then I did a short fellowship at UCLA, and there the preferred technique was Busin glide. So Busin glide, although it's challenging to learn for me because sheets and tackofolds are very easy and easy to learn technique. And Busin, I used to face a lot of challenge while pulling the graft. AC becomes shallow, iris used to come from the different side ports. So you have to put the graft here and then pull it from the opposite end like this. So this is the surgery of Busin glide. So coming back from UCLA, I started doing Busin glide, and I face the challenges every time. That when I push the graft, AC becomes shallow, iris pigment release, and all those things were happening with me. So it is done with the AC maintainer, and then inject the air. And 40 minutes to 1 hour is sufficient for graft attachment. And I always prefer to do anti-segment OCT just after the surgery to confirm that graft is attached or not, because next day taking the patient back to OR is more challenging in private practice. So, sorry. So I did a small modification that I want to see in Busin, show you in Busin glide. So Busin glide is a standard straight handle device, and your both hands are at 180 degree apart when you are pulling the graft. So because of this arms away from your body line, your hands become unstable and you become tired very soon. So just to take care of this issue, I'll show you. My preferred device is Busin glide, so which I've been using for many years, but every time I felt that there should be a way to make it more comfortable for myself. Looking at the design of Busin glide, it is a straight handle device with a groove on the other side for holding the donor lenticule. While using this device, Busin glide and DSAEK forceps are 180 degree apart, and both the hands of the surgeon are opposite to each other. Due to this, both the arms move away from the body line while operating. This causes instability of the wrist and fine movements become coarse. This happens because the elbow joint is unsupported during this step. Modify this design and make it more ergonomically suited. I modified the design of Busin glide and gave a 90 degree angulation from the handle. separate glide for the right and left eye was attached to the handle on the opposite sides. The internal diameter of the glide was 4.2 mm and the external diameter was 4.8 mm. The plate for placing the tissue was curved to hold the donor tissue in a natural curvature of the cornea. While using this modified device, although the tip of the glide is at 180 degree apart from the DSAEK forceps, but the handle of the device is 90 degree from the forceps. Due to this change in the design of the glide, the arm stays closer to the body line and making it more stable during the procedure. The surgeon sits temporally, and after placing the DSAEK graft on this modified Bushin glide, the donor lenticule is pulled into the glide. From external view, the position of instruments can be visualized. At this point, arm stays closer to the body, providing better stability and fine control on the surgical steps. So this is a small modification that I did in this device, and I'm very happy with this modification. And then I reviewed the literature and found that different studies have shown different results, although these studies are almost 15 years or 10 years older. And if someone is publishing something, he should be good at that. So like if I used to do sheets glide 10 years before, and my result now is much better with the sheets glide also. So results keep on changing. So you should not take anybody's that he has shown that 25% is a cell loss or 30% is cell loss. Doctors are giving good result with all the devices. And then endoglide with the Bushin glide, they have shown the Bushin glide is a 47% cell loss, which is impossible to think right now. And the third is the Bushin glide with forceps, and they have showed that the forceps is showing very high endothelial cell loss, and Bushin glide is better. So different studies, different outcome. You have to judge what works well in your hand. So in conclusion, successful DSAEK surgery can be done with numerous techniques. Minor donor tissue manipulation should be the target. Sheets glide has the least learning curve and easy for beginners. Tachofold technique showed maximum endothelial cell loss as well as lenticular attachment in my study that I did at our center. And 10 endoglide is a better technique in terms of endothelial cell loss. Different techniques works well with different surgeons, and there is no gold standard technique for DSAEK tissue insertion. Thank you so much.
Thank you, Bhupesh.